let's go into specifics with your own personal story and what that looked like for you.
Yeah, and maybe I'll do that, to try to, walk the listeners through, well, what do you mean when you say, well, the blood glucose targets are too high in type 1 diabetes, and they're going to lead long term to diabetes complications such as blindness, kidney disease, and etc. So maybe I'll try to, you know, tackle those both as I tell the
Great.
story. Um, so my husband and I have 3 children, and Lachlan is our middle child. He was 9 years old when he was diagnosed with type 1 diabetes. We were fortunate in that he actually didn't end up in diabetic ketoacidosis. As I mentioned, one of the symptoms of type 1 diabetes is urinating frequently. And I noticed Lachlan had been up in the middle of the night 3 times one night. And I remember saying to him, Lachlan, what are you doing, honey? Like just, stop going to the washroom, go to bed, what's happening? And he goes, Mom, I have to pee all the time. And so I said to my husband, I think I'm just going to take him in and maybe he has a urinary tract infection or something. I better go check that out with him. So we actually ended up, he did not have a urinary tract infection. He had type 1 diabetes, but we were fortunate in that he wasn't actually severely sick and had gone into diabetic ketoacidosis. So what basically happened is I took him into the emergency room that day because it was Labor Day Monday in Canada. It was the last day before school, before I entered grade 4. We had the diagnosis of type 1 diabetes. Obviously, we were in shock. I mean, I remember being in the ER going, what is this? Like, what? I kind of remember reading a little bit about this when I was a kid because we used to call it juvenile diabetes when I was growing up, but I really had no idea what was in store. So the next morning, we lived in a small town in Ontario, and they sent us to the Children's Hospital of Eastern Ontario, which is in Ottawa. And we had 1 week of diabetes education. And that typically, is ideally what happens when any child is diagnosed, that you have diabetes educators, nurses, dietitians, endocrinologists that teach you how to manage type 1 diabetes. So we went, and the first thing that we were told as soon as Lachlan walked in the door, the nurse said, don't worry, Lachlan, you can still eat anything you want. And I remember at the time going, what does that even mean? Why would he say that to us? Why would food change? That I remember it so clearly because everything was so confusing. So when you first go into diabetes education, they say, okay, here is what we're basically trying to do is now manage your son's blood glucose levels, because now that he can no longer produce insulin from within his own body, we're going to have to inject a medication called insulin, and you're going to try to balance the blood glucose levels. And the goal is to try to balance them the best you can. And you have to make sure, though, that his blood glucose doesn't go too low and it doesn't go too high. Because if it goes too low, he could actually, he will feel terribly. He could even have a seizure. And if it really doesn't get treated, he could go into what's called a diabetic coma and die. So, of course, as parents, that sounds terrifying. And then on the opposite side, if we go too high, that leads to the long-term diabetes related complications over time, blindness, kidney disease, nerve pain, etc. So right away, you realize, well, we're sort of on this tightrope. And so in order to give you a little bit of space to walk along that tightrope, in Canada, we're told keep the blood glucose levels between 4 and 10 millimoles per liter. In the United States, that's 70 to 180 milligrams per deciliter. And, try to keep within, those are the targets, for your child with type 1 diabetes. And so you think, okay, so those are the medical guidelines, away we go. Then they teach you to inject insulin. And then they tell you, we can still eat the way you normally do. And they explain to you what carbohydrates, fats, and proteins are. And you say, we actually need to dose the insulin for mealtime based on the number of carbohydrates. So we'll need him to eat this many carbohydrates. And I remember when we finished with the plan for the week, we had the most lovely dietitian. I still to this day, I think she's the nicest person probably I've ever met. But we put together what he was eating, and it was like over 200 grams of carbohydrates per day, right? In this 9-year-old. So my husband and I were like, right, we just have to do the math. We have to count the carbs. We have to weigh the food, and we just follow the instructions, and away we go. So the father that you reached out to is dealing with all of that in week 1. And pretty soon you realize as a parent, oh, I'm doing the math. And yet, even within that 4 to 10 range, that 70 to 180 range, his blood glucose levels are bouncing all over the place. And it's pretty stressful.
Wow. Okay, so I want to point something out. Also, I just want to point out that at the time you heard the introduction when we said you're a nutritionist, a dietitian, you're licensed, all this stuff. That was not at the time.
Yes, great point. So, no, I was completely clueless. And I mean, I tell people this all the time because I remember saying to a friend, maybe a month after Lachlan was diagnosed, he said, "Oh, what are you doing right now?" And I said, "I'm getting a PhD in type 1 diabetes." Like seems like my full-time job. But I had come, I had worked in international education. I'd worked for the federal government in Canada. I had no science background, like nothing since high school. I was an arts major, I had a public policy degree. So I actually, after about a year after Lachlan was diagnosed, I started taking some nutrition studies because we had, I'm skipping around in our story a bit, so bear with me, but we learned about the foods that worked better for Lachlan's diabetes, and we managed to have a lot more stability in blood glucose levels, but I couldn't understand what was happening in the body still. I still felt like, well, how are we doing this? Like, how does the pancreas work? How does everything work? And how does food interact with how the body works? So I then went and did my Master of Science in Nutrition and Integrative Health.
Got it. I wanted to point that out. I also wanted to point out if there was a super, super nice, dietitian in Canada that's amongst Canadians, you're talking about way over the top nice. You're already talking about very nice people, and she's even nicer than that. That's like a next universe
so
level.
Nice. Yeah. And
Nice.
Lachlan's diabetes nurse, we felt very fortunate. I mean, Lachlan still has a place in his heart for the nurse that day, who was the most loveliest man ever. And, I really think that people I think people who go into work with especially children with type 1 diabetes, the majority of them are absolutely lovely people who want to help people with type 1. And when we went back to these people a couple months later, and I can probably get to that in our story, going, okay, this doesn't work. And we've heard that you can reduce the carbohydrates to make life less stressful. They were actually open-minded and welcoming, and they helped us do that. But the conventional approach is not to teach that from day 1.
Got it. Yeah, and even what you're describing, I've never heard of before. Having an entire week is way more comprehensive than anything that I've ever heard of, regardless of the information given. That's I mean, still is very, very comprehensive. So I like that. This really occurred to me, as I'm talking to Bethany McKenzie, and especially the people like R.D. Dykman, and like you maybe didn't have the background in diabetes care, but you're talking to two very smart parents. Like RD and his wife are both doctors. Bethany's husband is a doctor. Like these are not idiots. These are smart people who are good at things, and they care. They're caring parents, and they're loving, and so they get the math, they get the numbers, and it's like, okay, got it. I'm on this. We can sort this out. Tell us what truly like a normal day of the life is for the entire family when somebody is suffering with type 1 diabetes and they are following the standard conventional advice.
Yeah, it's a great question. So I remember, I mean, there's so many different elements. The hard part is there are so many things that affect blood glucose. So you could provide the same meal to your child day in and day out at the same time of day. That helps, right? The body likes consistency, right? And type 1 diabetes really appreciates consistency. But there are so many things, like did Lachlan run around at recess, or did it rain that day and he stayed in? So he's less or more insulin sensitive, right? Because exercise and, improves insulin sensitivity. They're just, there are just so many things that affect it. So it constantly changes what happens on a daily basis. And so when we started, I remember it was only day 3 after diagnosis. And I tell this story often, but you have to give, when you are having quite a few carbohydrates at the meal, you actually have to give your child the insulin injection 15 to 30 minutes before they eat, so that the insulin medication has time to take effect, so that when the food's effects hits, you're trying to match that. Okay, so it may already sound crazy to you to say that, but there's all these issues with insulin variability too, right? So Casey, think, like, there's so many decisions a person with type 1 diabetes has to make on a daily basis. If I inject insulin into Lachlan's stomach or his arm, I get different insulin absorption rates. If I'm, having 5 units of insulin versus 1 unit of insulin, the variability of what can actually happen once the insulin is injected changes. There are also many different types of insulin. So you have to understand your child's particular insulin profile and how it works. When does it start to work once it's injected? When does it have its peak effect in the body, like its strongest, most potent effect? And when is it considered having, left the body? So all these things are going through your head as you're trying to do this. So you go, I can do the math, I can figure all this out. And then you're on this roller coaster. So it's day 3 after diagnosis. We've injected the insulin. We've counted the carbs. I've given Locke a wrap with white rice and chicken and vegetables inside. And halfway through the meal, he says he's full. Well, I've already dosed the insulin. So we said, you have to now, now I go, okay, I'm going to have to give him some glucose tabs to make up the difference. But, you don't know that. A lot of parents are still, and we forced him to finish that meal, and he's crying because he doesn't feel well because he's continuing to eat the meal, but we've injected the medication and we can't risk his blood sugars going low because he had too much insulin for what he was eating. So that's like a typical day with type 1 as you kind of learn this. And so, when I think about people like Bethany and RD, and we're all trying to do the math, but there are just too many factors that make type 1 hard to manage. Now, if you decide that you want to stay between the conventional blood glucose targets of 4 to 10 or 70 to 180, it's easier. It's easier. But when parents realize, well, that's not going to prevent complications, we actually have to try to mimic what the body normally does to maintain health. And for me personally, I saw a grandfather lose a foot when I was a teenager from type 2 diabetes. So I knew what like, my grandfather was diagnosed with type 2 diabetes in his 50s and lost that limb in his 70s. So I'm like, well, my son was diagnosed when he's 9. I can't have him high blood sugar, or I know what his fate will be. So, when you are trying to get closer down to, like, I want to have my child more between 4 and 7, or between 70 and 120, 130, that's harder to do unless you're very strategic with the inputs you put into the body. And the one input we have the most control over is the food we eat.